Welcome to the We Talk Health Podcast, the official podcast for West Tennessee Healthcare. Please be advised that this podcast is not intended to replace any medical advice. Always follow your medical professional's advice and direction. Nothing said in this podcast is intended to supersede or supplement the direction of your medical caretakers. If you have any questions, please reach out to us at wetalkhealthpodcast@gmail.com, and we will do our best to answer any questions you may have.
Welcome to another episode of We Talk Health. My name is Will Kwasigroh, and joining me again today is Bryan Thorne, Andy Akin, and Cathy Sudbury. They are all affiliated with Sports Plus and the Lift Therapy Center down in downtown Jackson, Tennessee. How are you guys doing today?
Good.
Doing well.
Fabulous.
Thanks for having us.
Awesome. Thanks for coming in. So today we're going to be talking about shoulder pain. Personally, I don't suffer from shoulder pain, which I'm very thankful for, but I know there are tons of people who do. So just right off the bat, how many people, if you have stats on it, how many people suffer from shoulder pain a year?
About 18 to 26% of the population at any given time will have shoulder pain. So that's about 1 out of 4 or 5 of every person you see walking down the street has shoulder pain.
That's a lot of people.
It's a lot. 1 out of every 3 orthopedic consults. So if you go to see the doctor, an orthopedic doctor, 1 out of 3 people are going to the doctor because they have shoulder pain.
Mm-hmm.
So yeah, it's a big problem. And about 70% of the population is going to have shoulder pain sometime in their lifetime. So that's even more of us. So you're going to probably, unfortunately, you probably will have it sometime. Hopefully not. But anyway, there's a lot of folks out there with shoulder pain, and then you ask why do they have shoulder pain, and there's a various number of reasons. It could be non-specific, which means the shoulder hurts, I'm not sure why.
Mm-hmm.
Go to the doctor, find out. Or impingement syndrome. Stats say about 44 to 65% of all shoulder pain is related to impingement. That's about half of them are related to impingement. We want to talk about impingement syndrome. If I could get into kind of the detail of what you may have heard of impingement syndrome.
Yeah, please do.
It's a pretty common. We're actually calling it subacromial pain syndrome now. That's the specific term, but impingement syndrome, and it has to do with posture and some things we can really work on in physical therapy. But if you think about, there's a bone called the acromion, which is at the top of the shoulder. It actually attaches to the scapula, which we'll talk about later. But it comes over the top of the shoulder like a hook, and it attaches to the shoulder at the top and front portion.
Okay.
And there's some structures that lie underneath that acromion, or it's called in the acromial or the subacromial arch. Some of those structures are a bursa. More importantly, there's a rotator cuff tendon called the supraspinatus. Anyway, and there's some ligaments, but there's a very small amount of space, about 16 millimeters, for all that stuff to fit in. When you elevate the arm, that space gets even smaller. Now, what happens to us as Americans, any tightness of our pectorals, our chest muscles, any slouched posture, and there's where it comes up again, can actually reduce that space to nothing. And after a while, you start getting pinching or impinging of those structures. That bursa, that rotator cuff starts getting pinched. It starts kind of getting sawed. And then sooner or later, you start getting a little bit of shoulder pain. It becomes inflamed and swollen. Those structures get swollen. Now you got less space, okay? So it's more swelling, you got less space. So it makes the problem even worse.
Wow.
So, and it gets worse and worse. And then over a period of time, you say, hey, I've got shoulder pain. Why? I haven't done anything to hurt my shoulder. Why have I got pain? And that's where impingement syndrome is and how it relates to posture. We can get impingement from doing overhead activities, repeated overhead, like a painter or someone who works overhead or does a lot of repetitive arm motions. There's more than one way to get it. But that's what we see, as we talked about in our last podcast about the neck. We see it posture related as those muscles get tight. Also, the back or the posterior shoulder muscles can get weak. But if you look at what we do all day long over our computers, we talked last time about the neck, how we have a forward head posture, but we forget about the thoracic spine or the middle of the back and the rounded shoulder syndrome that goes right along with what we talked about last time. And that really addresses impingement syndrome. And the good thing about it is it can be very much improved by exercise. In fact, exercise, given the right conditions and situations, exercise can be as effective as surgery in combating impingement syndrome. We're very fortunate to have all of the doctors in our area send their patients to physical therapy first before any type of surgery is indicated anyway. They always do send patients on a conservative treatment protocol anyway, so they're right in there with what needs to happen.
Well, I noticed you said it can be improved by doing exercise, but usually by the time they come to the doctor, they would probably need to come on to physical therapy and start those type of exercises with you guys to see exactly what we need to do, because me being one of these, I love to exercise. I'm going to go try to look it up on Google and try to do it myself, but probably not doing it properly because I'm in pain, correct?
Yeah, and the shoulder is very complex, so you can't just jump in there and do anything. A lot of us work on our front chest muscles, but really a good evaluation from a therapist, we're going to address the tight structures in the front. We're going to address the weak structures in the back. We're going to address the rotator cuff, the posterior shoulder girdle. We're going to address posture. We're going to address what you do at work, what kind of problems you're having and why you're having them. So we're going to do a lot of educating, especially early on in the evaluation process, to address this common impingement syndrome problem.
Well, Andy, I'd like to ask you one other question. When you were talking about shoulder pain, we all relate anything running down the arm or the back or it's something different. Can you describe what that shoulder impingement might feel like, or what people that are out here listening saying, hey, I do have shoulder pain, but is that what I'm facing?
Yes. Well, some type of shoulder pain can be actually coming from the neck. So we definitely wanted to defer that out and have a differential diagnosis, so we can want to clear the neck first of all. But typically the impingement shoulder pain is going to be pain in the shoulder, sometimes radiating to the upper trapezius or the neck muscle into the shoulder blade. If it gets bad enough, it can start going down the arm a little bit. But mostly that's not impingement syndrome unless it's a severe impingement problem that's been going on a long time. So usually it's going to stay around the shoulder and upper arm. That usually the outside aspect of the upper arm is usually where we're going to see that pain.
Yes, I'll just chime in there. Certain movements that we perform will cause pain or elicit pain, usually in the top side of the shoulder, the outside part of the shoulder going down the arm and that deltoid muscle there. Usually with movement. So there's like every time you move this direction, you'll have sharp pain in that area or towards the top of the shoulder, and that can be indicative or lead us towards the impingement diagnosis or course of action in therapy, as opposed to teasing out or kind of trying to find out if the pain is coming from the neck. Usually neck movements that your therapist can take you through, tease that out or test it out to see if the neck movements are producing your pain, or is the shoulder movement producing your pain, and we can help kind of tease that out in the therapy evaluation.
So I hear about the rotator cuff quite often. Can you explain, I guess when you hear the word rotator cuff, that's part of the shoulder that rotates. That's kind of given there, but can you explain exactly what it is and how it works?
Yes, Will, the rotator cuff, C-U-F-F, the reason I say that is we hear all types of pronunciations, in our area in the South here.
Sure.
But people just misunderstand. They'll say rotary cup or rotator cup, but it's rotator cuff. It's just like a cuff in your the sleeve of your shirt, basically. A cuff, it just surrounds the joint. There are actually 4 rotator cuff muscles. The one that's most commonly injured or in dysfunction or getting impinged upon or even torn sometimes is the supraspinatus. That's just a fancy word for the muscle on top, the muscle that's on top. It gets the most stress and force, as you can imagine, being in the position on top, helping to lift, but also underneath the shoulder blade has a chromium structure on top, a roof that kind of sinks down or can impinge upon this supraspinatus muscle. So it kind of is the one that gets the most stress and doesn't have much room to work, I guess. We ask a lot of it. So in therapy, we try to help provide space for that muscle, help provide appropriate flexibility around that musculature and the right support. Just as if you were on a team and you were having to provide most of the work for the team, you might get tired or fatigued or too much stress upon you. You need that help from the other teammates. So we try to address the other 3 rotator cuff muscles that people a lot of times don't know about, along with other muscles that support the shoulder blade, which we'll get into in just a second about the role of support as far as providing a good sound foundation for the rotator cuff to work off of. We'll talk about that in just a minute.
Talk about rotator cuff tears. 40% of the population over 60 will have some type of rotator cuff tear. Now, we're not talking about a tear that necessarily requires surgery, but 40% of Americans over the age of 60 will have some type of rotator cuff tear. And we go back to that impingement syndrome. It starts off, with pinching and inflammation of that supraspinatus tendon that Bryan was talking about. Then after a while, that tendinitis or the inflammation turns to tendinosis, which is actually starting degeneration or sawing into or fraying of that. Once it gets sawed into deep enough, then you're going to end up with the third stage, which is a partial rotator cuff tear, where I think about that tendon may be sawed in half or something or somewhere less than half of it. Once you get into the last possible phase is the full thickness rotator cuff tear, and it's usually that supraspinatus tendon where it's completely ruptured and it's no longer able to support. And Bryan talked about the cuff. All those rotator cuff tendons have to work together. Once you have one of them gone, then the whole shoulder complex starts to lose stability. You start you can't lift overhead, and you start getting more pain, more instability. So that process, we want to talk about rotator cuff tears. So, physical therapy can help in any phase of that. Once you get a full tear, then you kind of got an option between surgery or therapy, and you have to really tease that out, function-wise, pain-wise. And again, the doctors are great around here about getting them to therapy first, trying that out. Kind of surgery is the last indicator or last hope, I guess, to salvage that rotator cuff tendon. But surgery is often indicated on a full tear. But there's about 250,000 rotator cuff surgeries done a year in the U.S.
Oh, wow.
There's a lot of them, a lot of cost to the medical system. I will say national statistics say about 25% of rotator cuff repairs fail, which you don't want to hear about. But me and Bryan discussed this earlier. In this area, I think that's a national statistic, but in this area, that's extremely rare. And I think a lot of it has to do with the medical care in this community. When you get, as soon as the doctors do the surgery and they go through the protective measures, they get them to a physical therapist, and we take over. And the first thing we do when we get them the first day after a rotator cuff repair, they're usually in their sling. Sure. They're protected, and we educate what you can and can't do.
Education, that's important.
It's the key role. And also to tell them that the rotator cuff repair rehab, which is kind of the next thing we probably wanted to talk about, because it is a long rehabilitation process. It comes in phases. You got to do a phase one, which is the protective phase. We get a little bit you really work on range of motion, not a lot of strengthening. Phase two, you begin the strengthening, continue range of motion. Phase three is strengthening and stability, but patients don't know that. So we educate them, hey, you can't jump phases. You've got to start with phase one. You got to protect this thing. You're talking about healing structures, soft tissue structures. You got to protect it. You got to keep that sling on, usually 4 to 6 weeks. Mostly about 4 is what they're doing now. But I've had patients come up the first day and ask me, hey, can I pick up a toolbox? Right. I'm like, no, you can't even pick up a cup of coffee right now. So, education is huge. And so we and the physicians are a team. It's a team approach. Sure.
Yeah, I'll just chime in there. It's kind of a 3-prong approach. Yeah. Like you said, it's us as a therapist, it's the surgeon, the physicians, and also the patient. We must all three be playing our roles correctly to achieve a successful rehab. We've been very blessed. The physicians and surgeons in this area are highly skilled, and we just early in our careers we've been working together. Andy and I, 26 years, just saw the importance of needing to educate the patient, because many times when they are waking up from recovery, they're coming out of anesthesia, they're not exactly being able to focus. Trying to wake up and to get all these instructions to go home with, as we see in healthcare, wanting to get people home faster. So sometimes once they get awake, they say, I don't remember, what'd your doctor say? I don't remember anything they said. They'll tell us, well, that's okay. We'll help you through that and talk you through that, and even contact their physicians if they need us to. We try to stay in close contact anytime during physical therapy rehab. That's great. As needed as well.
You mentioned therapy happening in phases with the rotator cuff.
Surgery or repair, yes.
And you said people should not or cannot jump phase. What would happen if someone did? Say I were to have to go through that, and I wanted to pick up, I don't know, my phone or a cup of coffee, but I'm not ready to do that. Is that like pretty detrimental to
Yes, you could very much tear that surgery. You could tear it up, or actually have it to release or let go and not heal properly.
Wow.
And it goes back to that percentage, 25% failure rate in the United States. We just don't see that here in West Tennessee, in this area, because I think it's because of the doctors and the physical therapists working together. I was telling Bryan, in our practice, I've been doing this 26 years. I can count on one hand how many failures I've seen. So
wow.
I know that number is way less than 25% in this area. It's a national area. I don't know if it's due to surgeons or not getting to the right physical therapists. I don't know what the problem is nationwide, but I know in this area it's way less than that. I think that's, again, goes back to our medical community, knowing what to do and when to do it.
And how to educate that patient. You guys do a great job of that.
Education is key, specifically with rotator cuff rehab.
So what about posture? Does that play a role in shoulder issues and shoulder pain?
Yes. The body, if we look at the whole body, the body is designed to be its best function when it's in what we call, in the therapy world, neutral position.
Okay.
It's similar posture as if your mom said, son, stand up straight. So your body has this neutral position that it's the strongest and safest to work in. And when we have poor posture, such as Andy alluded to earlier, working at our desks, working at our computer screens, looking at our phones, everything we do is in front of us. So it tends to pull. We mentioned in the last podcast, our head, weighs 8 to 12 pounds. It drifts forward. Our shoulders tend to drift forward. We tend to sit in our chairs and kind of relax, or our low back will sag over time, and the whole body tends to pull itself down, and that brings the shoulders rounded forward.
Sure. The day we recorded that, since the day we've recorded that, every time that I'm on my phone, I'm like, nope, pull my head back, make sure I have good posture and all this kind of stuff. So you guys taught me even here. So
great, fantastic.
All right.
I've watched you through this podcast. You've straightened up 3 times.
Yeah.
But our chest muscles are very powerful muscles. A lot of the folks even at the wellness center or fitness center, we'll see them come through, and even guys that I've known or gals I've known that'll work out a lot, they'll want to work those muscles because you can see those results quickly. They provide the shape and that people are looking for. Those muscles are so powerful. Sometimes they overpower the rotator cuff muscles, which are underneath those muscles, and they must be worked. But you don't see people working these muscles in the gym setting, and that's what we want to do in physical therapy, is teach you how to strengthen this undergird of support, if you will, that'll make that ball joint track properly to where it will not scrape or rub on these other structures nearby and create that tendonitis or possible tear in the future. But one last thing I'll say about posture, when your shoulders come forward or sag forward or droop or slouch, that brings you out of that neutral position that I mentioned earlier, and so things start to rub and get out of balance, and the wrong musculature gets tight, and it sets off this direction it's hard to get out of if you let that go on too long, because muscles tend to shrink to the size that they're used to being in. So we'll try to help you in therapy to educate you, to help stretch the right ones, strengthen the right ones at the appropriate levels and appropriate times, if you will.
That's great. So what about a frozen shoulder? What is that? And does physical therapy help unfreeze those frozen shoulders?
Frozen shoulder is a weird syndrome. About 3 to 5% of the population will end up with frozen shoulder. It's actually, the term is adhesive capsulitis, but it's actually where the shoulder, it's got a chronic inflammatory response, and the shoulder joint produces these fibroblastic proliferations, and that doesn't.
That's a fancy word.
Yeah, it's a fancy term.
That?
What it means is actually the shoulder joint capsule actually changes composition. It's instead of it being very lubricated, like if you change the oil in your car and everything's lubricated, and the oil is very non-viscous or very fluidy, and it changes shape to a very viscous. It would be like changing your oil with cold molasses. Now everything's very viscous and tight, and it doesn't move. Then you add along with that very painful. So basically, what you end up with is a tight, painful shoulder joint. You go to, and it happens very insidiously usually. So it sneakily happens. You go to put on your shirt one day, and it's like, well, my shoulder is tight, and I can't hardly put my shirt on. And then a few weeks later, you're like, I can't even put it on at all. I can't reach behind my back to tuck my shirt in. I can't reach behind the car and to pick up something in the back seat of the car. I can't reach anything overhead shelf to put anything on, dishes away or anything. And all of a sudden, before long, your shoulder tightens up to where you can't move it in the way that you need to for your everyday life. It's tight and it's painful, and you don't know why. And most of the situation is, and by the way, 70% of frozen shoulders are female. Sorry, Cathy.
Well, I was going to say, everybody I've ever known was a female that has had that, because they'll go, I can't touch the back of my hair to dry it.
Yeah, so 70% are female. 20% of the diabetic population will end up with frozen shoulders, so that's a bigger percentage, probably having to do with vascularity or something. We also know that it's thought to have phases, like there's a freezing phase and then a frozen phase and a thawing phase. Those phases are supposed to last somewhere between 4 to 8 months each, or with a lot of overlap. There's a lot of research out there, but nobody knows exactly. Well, the biggest problem is that nobody knows why.
Sure.
Most of the problem is idiopathic. I don't know why it happens. Now, it could be, they also know it could be due to a small tear. It could start with an inflammatory process like impingement, what we talked about. But for whatever reason, the shoulder joint freezes up. And we know that it's the most mobile joint in the body. So when it starts to freeze up, before long, you've got half of your range of motion gone and you don't even realize it. Like I said, it just sneaks up on you, not sure why. The great news, though, Will, is that in 90% of the cases, and I'm going to use a study out of the North American Journal of Sports Physical Therapy by Levine and colleagues, 90% will improve with non-operative care.
That's good. That's encouraging.
That's 90%. In just as early as 4 weeks, patients will result improved range of motion and decreased pain. Not necessarily that's all they have to come, but after 4 weeks, you're like, man, I can really tell a difference just with these exercises and physical therapy. And again, we know the anatomy. We know what exercises to prescribe. They perform exercises in the clinic. We prescribe a very structured home exercise program. And then we use our manual therapy skills to do some gentle progressive stretching in those ranges, internal, external rotation, flexion, what we call scaption, the different motions that the shoulder does, and gradually get it back over time. And they do exceptionally well. 90% is good for any category.
Oh, sure.
But that's specifically that category of frozen shoulder. They just get better with physical therapy. They just do.
So, Andy, I'll play advocate here. You keep using the words freezing and frozen. Is the shoulder actually cold, or what's going on there?
Freezing means locked up. It means that joint capsule is tight, and the shoulder doesn't move in the ranges it's supposed to. So it's not cold, but it's stuck. So it doesn't move. Those motions, the most mobile joint in the body now is not mobile anymore.
That's right. I try to tell patients, too, you kind of picture saran wrap. The capsule around the shoulder joint is kind of like saran wrap. If you made a fist and you took a single layer of saran wrap, wrapped around your fist, you could probably still open and close your fist just a little bit. But in a frozen shoulder condition, the capsule gets highly vascular and sensitive and inflamed. It's almost like a bloodshot eyeball. Capillaries get, instead of being a white, shiny, pristine look, it's more of a bloodshot look. It gets really thick. So if I took that saran wrap around my fist and I wrapped it several times, and then I tried to open my fist, I couldn't open it at all. It'd be really stiff and stuck. So we have to get all that inflammatory process calmed down through NSAIDs that it's just non-steroidal anti-inflammatory type medications your doctor can help you with, or nurse practitioner. Sometimes they'll use steroids injections to calm that down. Or just time even, or sometimes we use ice or some other medicated rubs and therapy. And if that calms down enough, we can begin to work that saran wrap covering, if you will, the capsule, begin to get it to stretch out. And then sooner or later, that ball joint can move within that capsule again, normally not hurt as much.
Typically someone who is going throughout their day-to-day does not plan for physical therapy. I don't have to go to physical therapy right now. That's not in my normal thing. And it probably varies per patient, but are people coming to visit you guys once a week, multiple times a week? Let's say I had a frozen shoulder and I just could not move it. And is that an appointment that I would see like maybe on Mondays or whatever day of the week, just once a week, or is it multiple times a week?
Usually 2 to 3 times a week.
Okay.
And again, depending on how bad it is and how much you can do on your own, how much you can do in your home program is going to be a big part of it.
Gotcha.
We'll tailor that each program and our availability, your availability to whatever your schedule is, and balance that out with what stage of the process are we in. When we first started a career, I tend to just would go with whatever was on the prescription.
Sure.
3 times a week, 5 times a week, 2 times a week, which is great. But over the course of our career, we begin to think about and discuss with the patient, the customer, and see what stage they're in, and say, insurance begins to restrict some visits. How many visits can you actually have this year? So we'll need to budget those and use those wisely. When do you need me as a therapist to coach you into what you can do on your own? Maybe it's going to be 3 times a week at first. Maybe it'll be twice a week later. Maybe it'll be once a week, once a month. Something like that. We can tailor that to each need and each injury and the insurance benefits.
Sure.
Whatever they have, the plan they have.
I've had patients that are, I live way far away, or my work hours are crazy. So I'll say, well, come once a week, and then make sure you do these exercises the other 6 days.
Yeah, that's what I was going to say. I feel like the home program that you guys give patients like that is it is vital in ensuring success with this kind of stuff.
Yeah, the shoulder is so complex, and that's where, especially with this frozen shoulder, it really does help to get a skilled therapist that can stretch your shoulder in different directions. You can get a lot of your range back with the home program, but that final 10-15% really is beneficial if you have somebody to stretch it for you. So that's really kind of where manual therapy, physical therapist can come in and really get that last few degrees. Can't get all the way behind my back, or I can't get all the way over my head, so we can help a lot with that.
Yeah.
And there's because you just can't stretch yourself in those last few degrees of ranges. You can get most of it, but those last few degrees, you really need some help getting there.
Yes, it kind of goes along as far as teaching them and coaching them. What is that saying that says, give a man a fish, you can feed him for a day, or teach a man to fish, you can feed him for a lifetime. So we kind of use that approach in therapy. I can treat a person for a day, or I can teach them and help them, hopefully, for their lifetime.
Yeah.
Of course, stay in touch with us.
Yeah, of course.
Sure.
So what about the shoulder blade? What's the importance of that?
Well, Will, it's a great question. The shoulder blade, a lot of people don't realize that the shoulder blade houses or has the socket for your joint, for your shoulder joint.
I didn't know that.
Right. So it's easy to think about, as far as the hip joint. You're like, okay, yeah, my hip joint's right here. My pelvis right there at the side. It's a part of that. But your shoulder blade, which, you can reach around or see it move on somebody's back up and down, it's all over the place. What I mean is it's a very mobile joint, and the socket is actually attached to that. And so it must be supported by musculature. And there's so many muscle groups that attach to the shoulder blade. We call it the scapula in therapy, but the shoulder blade muscles must be a strong, secure platform so that the rest of the arm and the hand and the fingers, whatever you're doing that day, can perform off of that strong platform. So if there's any of those muscles that are weak, that platform begins to become unstable and shift and twist and turn, and may cause scraping or dysfunction or rubbing, or creates tendinitis, tendinosis, a tear. So hopefully, if we can catch that early, when you first have pain, just contact your physical therapist. Through a program, I'll just plug the direct access. You can find us, our therapist, at the Wellness Center, Lift Wellness Center. Just Google that, tap on therapy, and you'll find our phone number down there. But most insurances, you can just make an appointment with us, and we can just evaluate you and see, hey, where is this dysfunction coming from, and how can we help you? Hopefully we'll get you the right exercise right away to get this taken care of early before it progresses to something more serious.
Bryan, you mentioned direct access, which is really a fancy term for self-referral. So if anyone is out there and experiencing some shoulder pain, they can call you directly. It is not really skipping the doctor. It is you evaluating to see if that patient can come straight to you, go ahead and start the exercise program. But if you feel like they need the doctor, you will refer them back out to their doctor.
Absolutely. We have numbers and contacts for all the doctors in the West Tennessee area and beyond, for that matter. We rely heavily on the doctor's care and the nurse practitioner's care. we highly respect those individuals and what they do. We feel like we could be sometimes an easier access, an immediate benefit as far as a person being able to get to us and get help quickly. Many times they do need a physician involved, and we'll help them get in contact with their physician and make sure they get the right care that they need. Sometimes it hasn't progressed to that yet, and we can help them right away with some things if they just contact us directly, and we can set up a program for them to begin. And hopefully we'll see some improvement. If we don't see some improvement, we'll be the first to tell them, we need to contact your physician or nurse practitioner and let's get this taken care of, because our first plan of action is not having the results that we thought we should have. And so if that happens, we'll get them in there right away.
Well, wrapping this up, it's obvious that you guys have touched base on exercise is so important when you have some shoulder issues. But the main thing is important, I feel like, is that you really need to have a physical therapist really look at it and help you get on the right track to correct it.
That's right. And we talked about how complex the shoulder is, and we could talk for the next few hours about how complex the shoulder is and all the different conditions and how confusing they can all be. So the first thing we need to do, this is what we do. So if the patient comes to see us, the first thing we're going to do is evaluate them and figure out which of these problems they have and why they have shoulder pain. And secondly, we're going to educate them not only on the right exercises and the right strategies, but what they're doing that's causing this. And usually, like we already talked about, it could be posture related, it could be work related, it could be something else they're doing. But we got to educate them first and foremost to have them stop making this problem worse. Then develop a plan of treatment, and that plan of treatment is going to entail exercise. It's going to probably entail some manual therapy, some stretching, some postural correction activities, and then a home exercise program. And that's all going to be an all-inclusive. And then if it is something more severe like a rotator cuff repair, then we'll educate them and take them through those phases so that they don't jump phases, they don't risk re-tearing or causing damage to their surgery. So there's a lot of information, a lot of training, and a lot of management that goes along with what we do. But we need to get them in the clinic to see them so we can evaluate them and then treat them and take them through this process.
Yeah, one other thing I'll throw in there, if I can use one of the words I think that stood the test of time, is the word cool. Can I say that? One of the coolest things about our job, I think, we think of it as, somebody used this term earlier in my career, physical medicine. So we want to look at how the person is moving. Okay, what is your physical activity? It's almost like being a detective when they come in for the evaluation. You're trying to find out what has caused this. What are the daily habits of this person? Where are they working? What are they doing? How are they using their body? How are they lifting? Are they using the proper musculature? And then what can we do as physical therapists to teach you and train you how to use these things properly so you will not become injured and not have to come see us? Such as, one thing real quick, I'll just throw out there about the rotator cuff. You want to hold things close. You hear about back safety, holding things close to your body, picking up close to your body. Well, the same thing is true for the rotator cuff. If you have your palm up and you pick things up close to your body, you're going to be pretty safe most of the time, as long as you test. Don't try to lift a dump truck full of dirt. Nobody can pick that up.
Well, darn, I was going to do that this afternoon.
Exactly. You might can do it.
Or don't do like my husband, climb on top of the kitchen table to change a light right after surgery.
Oh, that'll do it.
But where the rotator cuff musculature becomes susceptible is when you hold your arm out away from your body. The elbow is away from the body. The palm is down. It's like you're reaching out, almost like if you're reaching out to hang up some clothing, or reaching in the back of your trunk to pick up groceries out of the back of your car, toolbox over in the back of your truck. That type of motion with the arm is where the rotator cuff becomes strained. So the body is not designed to handle much weight in that position.
Gotcha.
So when it's close to your body, it can handle much more weight because you're using the biceps musculature and other muscles that can help do that. They're designed for that. So it's part of our job to help teach and train people how to use their bodies properly, prevent injury.
What not to do. Don't lift that toolbox out of your pickup truck with your arm completely extended straight. That could be a problem.
This has been a great conversation. If someone were having shoulder issues and they wanted to try to utilize the direct access program that you guys offer, what's the phone number they can call to get that process started?
Our phone number at the office is 731-421-6950.
Okay.
And you just call, make an appointment directly with one of our therapists here or any of our therapists.
Perfect. That phone number is going to be listed in the description of the podcast as well. So if you still need to reference that, you can find it there, as well as the Lift's website. Bryan, Andy, Cathy, thank you guys so much for coming in today. This has been a great conversation.
Thank you.
Always good to be here, Will.
Absolutely. Thank you. And this has been another episode of We Talk Health.